So what's the difference between locally advanced and metastatic?
It's again, I think it's beauty in the eye of the beholder. Locally advanced is primarily in clinical terminology disease that has grown to a point where surgery either would not be recommended, or if surgery were done, then it would be extraordinarily morbid or cosmetically disfiguring or unlikely to cure the patient. So if it's the same tumor that has recurred, for example, in the parotid area a couple of times, and we keep cutting and we keep excising this, and it keeps coming back, and we all have patients in our practice with that, then I think after one or two attempts at definitive surgery,
what's the difference between locally advanced and metastatic?
Radiotherapy, and the tumor comes back but has not metastasized anywhere, those in my mind would be considered to be locally advanced unresectable. So I think that's where the true power of a multidisciplinary group comes into play, where we get input from really top-notch surgical oncologists, plastic surgeons, and then of course radiation oncology and us to try and decide, if we don't believe that surgery is going to cure this patient, what is the best pathway forward from a non-operative standpoint? And of course metastatic is defined as, in the trial, in these trials so far that have been conducted, metastatic has included those patients with regional lymph node metastases. That was considered part of the metastatic cohort. And then, of course, those with distant metastases as well, lung being the most common site.
So normally you said radiation doctors were very important part of the multidisciplinary team. So one part of radiation is you resect it, and then you give radiation for adjuvant to prevent recurrence. But one of the other parts is, I guess, before checkpoint inhibitors came into play, and when you just had chemotherapy, that would kind of maybe give a response, but not for a long time. Was radiation the first option?
Yes. So typically in those individuals with locally advanced disease, you really need to try and control the disease before it causes more symptoms. And that could include symptoms such as bleeding, necrosis, foul-smelling discharge. Radiation can serve as an excellent palliative mechanism or treatment modality to help these patients. And then we tended to add in the appropriate patient chemotherapy to the radiation, both for direct cytotoxic effect as well as for radiosensitizing effects. So yes, radiation was a big, or is still a very big part in what we do with cutaneous squamous cell.
So in the phase 1, phase 2 trial that you were talking about, locally advanced and metastatic both were involved. So did those, how many therapies did they get previously? Did they get radiation? Did they get prior chemo in these patients, or were they not pre-treated?
No, the vast majority of patients on the phase 1, phase 2 trial for Empower, which is the cemiplimab study, were pre-treated. Most of them were actually heavily pre-treated. More than 50% had received some form of systemic therapy previously, typically chemotherapy or EGFR-targeted therapy, and greater than 70 to 75% of them had seen radiation as some treatment modality at some point in their course. So these were heavily pre-treated patients. So there was a small percentage of patients that had not received previous systemic therapy, but the vast majority had, and that's typical of the population. At the same time, being an early clinical trial, very appropriately so, patients who were immunosuppressed, patients who had concurrent chronic lymphocytic leukemia, patients who had previous organ transplant in their history, or organ transplant recipients, were excluded from participation in these trials. So the caveat there is certainly it's still a selected patient, but still a patient that we see routinely in our clinical practice.
So because of trial, you're saying that the ones who had some immunosuppression because of, or immune transplant, somebody with HIV or everything was excluded from the trial. So these were kind of patients who were not technically immune suppressed when they came into the trial, and they just had this chronic UVA exposure. Now tell me a little bit on the trial. Was there any biomarker selection? Like, we are kind of, precision medicine is all about, nowadays tumor agnostic. We have the microsatellite Instability, which we pick up on in colorectal cancer, which, and that's been approved for others, right? If you have MSI high, you can get checkpoint inhibitors across the board. So in this trial, was there any selection for microsatellite instability, for tumor mutational burden? Because now certain tests can do tumor mutational burden.
Correct.
Which is being used in lung cancer. So what about this trial?
So in this trial, this was a completely unselected population. It was primarily histologic diagnosis. But in my mind, that is where the field is headed, is biomarker-driven studies, and trying that to me is really the holy grail of what we are doing with immunotherapy. And trying to understand, which patients benefit the most from immunotherapy, which patients are more likely to develop a response or no response, and more likely to develop side effects. So one of the most common markers that we have utilized across skin cancers, and as you know, in many other tumors as well with immunotherapy, has been Pdl One Immunostaining. And this is on the tumor itself, on the tumor block, the paraffin-embedded specimen, either on the tumor, or Pdl1 can also be expressed on lymphocytes. One of the problems with that is the high variability in definitions. So for a positive stain, depending on which particular Pdl1 test that one uses, one could call a 1% of cells being a positive result, greater than 5%, and in lung cancer, certainly
50%.
greater than 50%.
Right.
So the question really is, in my mind, is that's not been adequately standardized, and definitely not so for a cutaneous squamous cell. More importantly, what is critical and what we have learned now over 5 to 7 years of Pdl1 history is that patients who have a high Pdl1 expression in their tumors do potentially have a higher response to anti-PD-1 or Pdl1 agents. But the corollary is not necessarily true. That means patients who are Pdl1 negative by the test that you have used are not those who don't respond.
So they can still respond.
Still respond, and therefore I would not deny a patient an anti-PD-1 agent when it's indicated in a given case simply because their Pdl1 status is 0%. So I think that's one of the take-home messages, which is critically important. And if you look across the board in tumors where anti-PD-1 agents have now been approved, so you're looking at melanoma, kidney cancer, bladder cancer, lung cancer, if you just average them out, and some publications have already come up, the response rate on an average is about 30%. It's higher in melanoma. For example, for therapy-naive melanoma, it's about a 40% response rate in the first-line setting, but it's lower in kidney cancer. It's about 22% there. So why is there differential even between tumors? So there have to be certain tumor-specific factors. If you look at the ones in these cohorts who are Pdl1 positive, the response rate sort of peaks up towards 50%. But the ones who are Pdl1 negative, the response rate is still about 12 to 14%. So there's a substantial population of patients that would benefit. So I don't think this is the end-all, one-all biomarker from a Pdl1 standpoint. Even in the phase 1 trial where they looked with CSCC, where they looked at Pdl1 staining, it was not predictive of response, or it did not correlate directly to response in that setting. If one combines these with other biomarkers, for example, CD8 density or tumor mutational burden, maybe we'll have a conglomerate of biomarkers that may allow us better to define which patients will and will not respond. And hopefully the field's moving there very quickly.